Thanks, friends, for watching today's lesson. I chose for you today an important topic. It's a clinical condition that we see quite a bit of, and also I get a lot of questions about it from surgical trainees and students. And these will be the cystic lesions of the pancreas. As I said, this is a very common clinical scenario. So it is important to have an idea how to manage them. If we find a cyst, what are we going to do? In general, this entity or the cystic lesions of the pancreas is a heterogeneous group of lesions with variety of reasons. And in certain series, almost 50% of them are pseudocysts that do develop from previous attack of acute pancreatitis. And indeed, we see quite a lot of these patients, and that's in particular people who have acute and chronic pancreatitis caused usually by alcohol abuse. Due to the modern imaging that is used for a variety of illnesses, and that imaging is usually in the form of a CT scan or MRI, the detection of these cystic lesions have increased dramatically with the modern era of advanced imaging technology in medicine. To the extent that certain series, the estimation varies from 2 to 15% of patients who get a CT scan or MRI, you might see a cystic lesion of some sort in the pancreas. So majority of these cysts that we see, in fact, turn out to be benign, as you will see. But there is a group of them that could be either malignant or pre-malignant, and hence the importance of studying cystic lesions. They can happen at any age, but we see the incidence of cystic lesions of the pancreas do go up and rise up with age, to the extent that if you image people above the age of 80, almost 37% of them will have cystic lesions of the pancreas, and the majority of those will be what we call a side branch IPMN, which is totally benign, but in some of them, they might need to be followed up, as we will see. Now, when we talk about any clinical issue, we just need always remind ourselves that we need to know if we say a solid mass in the pancreas, we need to have in our head what is actually causing a solid mass in the pancreas. When we say cystic mass in the pancreas, equally, we start asking ourselves. I got for you this WHO classification for cystic lesions of the pancreas, and that's based on the histopathology examination of removed cysts. That's a little bit too complex. I just wanted you to be aware of its existence. It's not much different from what we know in general, but we will make it simpler. So I have divided them for you into 4 separate categories. We did not include here the pseudocyst because the pseudocyst is not a neoplastic process. So I have included only the neoplastic lesions. IPMN stands for Intraductal papillary mucinous neoplasms of the pancreas. Now, this entity is discovered relatively recently in the 1980s with the increasing use of CT scan and MRIs. It was first described in Japan by Japanese doctors who diagnosed them and given them the name of intraductal papillary mucinous neoplasm. Basically, well, these are, particularly if they affect the main duct, they are some sort of neoplastic process that lead to metaplastic changes in the epithelium, lining epithelium of the pancreatic duct, and the lining epithelium could be either pancreatopapillary epithelium or intestinal epithelium or gastric alveolar gland abnormalities or metaplasia. So there are three histologic types of them when they are examined under the microscope after removing the lesion. Now, with IPMN, we have to divide them into three types. The main duct IPMN, when the disease affects only the main duct, the side branch, which is again limited only to side branch, and the combined. And these are three different pathological entities, because main duct is serious and it almost certainly will progress into cancer if you leave it long enough, which means that if the pancreatic duct is involved, we have to keep a close eye on them and advise the patient to have surgery if there is any suspicion of rapid growth or malignancy. Now, majority of these will have either intestinal metaplasia or pancreatopapillary epithelium, while in the side branch, usually it's gastric foveolar epithelium. And in this situation, it's only the side branch of the main pancreatic duct are affected. We do also have the combined variety. Now, the combined variety is a bit tricky because for practical purposes, it should be considered and treated just like main duct, because the main duct will be involved in this situation by the disease, which means that the treatment will be more or less the same, but the risk of having cancer in these situations seem to be a bit less than when the main, compared with the disease when the main duct is involved. So the IPMN is one of a major group of cystic lesions of the pancreas, and amongst the neoplastic cystic lesion, it is the majority. All the others are relatively rare. Second one, we go to the mucinous cyst or mucinous cyst adenoma of the pancreas. This is usually manifested in the form of a single cyst found on a CT scan or MRI within the substance of the pancreas. And usually it appears as a unilocular single cyst, typically occur in women in their 40s and 50s. This lesion is pre-malignant and should always be treated surgically whenever it's diagnosed. The other one is a serous cyst adenoma. Now this is called the grandmother cyst because it happens in women in their usually in their 50s, 60s onward. They are totally benign lesions, and there is no documented cases of transformation of serous cyst adenoma into malignancy. So if they are not symptomatic, they will be left alone. The fourth one is a rare, very rare tumor happening in young women again in their 20s usually, or 30s, and it's called the solid pseudopapillary tumor of the pancreas. It's a malignancy that's rare and of low-grade potential. It can metastasize and recur, and that's why it is important and has to be treated surgically, but it is a very uncommon clinical problems. Now, the epidemiology, I have mentioned to you a little bit of that, but mucinous cyst adenoma is regarded as the mother cyst because it happens in ladies mostly in their 4th to the 5th decade. As you see, 95% of them are females. Serous cyst adenoma, again, 70% of the cases occur in females. They are women in their 6th decade of life, above the age of 50 at least. SPT is cystic pseudopapillary tumor of the pancreas. That happened in women in the 3rd decade of life, in their 20s, early 30s. Perhaps 80% of them again are in females. And then we go to the IPMN. And the IPMN is the main duct, a branch duct, mixed and main duct. And here, and we see that there is a higher incidence in females, where 55% of them are of the patients are females, compared to 45 men. This disease usually occur in people in the 6th and 7th decade of life. So it's disease mainly of the elderly, and that's where we often see it and find about it. Most of these lesions are benign, and usually they are discovered incidentally. Now, how do they present? As I mentioned, they come to your attention usually incidentally. They do not cause specific symptoms unless they lead to pancreatitis. And any one of these lesions could actually lead to pancreatitis because they could involve or compress the main pancreatic ducts. And this scheme shows us the distribution of a variety of types of cysts. This is a pseudocyst. Usually it's in the lesser sac in the body and tail of the pancreas. This lesion, as you see here, the main pancreatic duct is dilated. Now this could involve any part of the pancreas. Usually it involves the body and tail of the pancreas. So this is a main duct papillary mucinous neoplasm, intraductal papillary mucinous neoplasm that's involving the main pancreatic ducts. Here we have got a mucinous cyst adenoma, which is multiloculated, but often on CT scan and MRI it looks like a single cyst. Which could be septated at occasions. So that's the typical appearance of a mucinous cyst adenoma, and it typically happens in the body and tail of the pancreas. Serous cyst adenoma can occur anywhere, more often in the body and tail of the pancreas again, but it could happen in the head and answered process of the pancreas. So serous cyst adenoma, when you see it, it's microcystic and multiloculated, multiseptated, particularly when you do MRI scan for the patients. Very occasionally, neuroendocrine tumor could degenerate and lead to a cystic necrosis of the tumor, and there will be some viable neuroendocrine tumor cells in the wall of the cyst. Unusual, but neuroendocrine tumor are known to lead to cystic changes that could look like any pancreatic cyst. And here we have the side branch, where the side branch is dilated and forming cysts. This is what we call a side branch intraductal papillary mucinous neoplasm. Now I thought I'd show you the imaging, the typical imaging characteristics of each of these lesions. How do they appear? And here I have got two CT scan, one of them for a patient with serous cyst adenoma. I'm sorry, this is the other way around. I didn't detect that until now, but this is a serous cyst adenoma where the lesion is multi-loculated, and you see it has got a lot of septa in it. And this one is the mucinous cyst adenoma, so it's crossed. So mucinous cyst adenoma usually is looks like a single cyst, homogeneous more or less. There might be one or two septa in it, but if compared to the serous cyst adenoma, the serous cyst adenoma will have a large number of septa inside the lesion. And again, I'm sorry for the image here, labeling that was inaccurate. Now, how do we manage these patients? And in general, when we see these patients, we will go mainly through their history, because as we seen before, that majority of cysts in the pancreas are pseudocysts. So we need to know whether the patients had any attack of pancreatitis recently in the last few months or not. That's very important. We do get their tumor marker assessed in the form of CA19-9 to ensure it's not elevated, because if it is elevated, then this might indicate a pancreatic adenocarcinoma transformation. They will all get a CT scan and a pancreatic protocol, which is different from the protocol done for the rest of abdominal pathologies. It's the sequence of the imaging that is given, and also the time intervals between different phases. Very often you will see, once we see one of those cysts, we will request MRI of the pancreas plus MRCP. The benefit of the MRCP is that it will add a lot of details to the main pancreatic duct. So we will be able to study the main pancreatic duct in better details than the CT scan, and that's why we request the MRCP. It also may detect nodules in a more accurate way than the CT scan. So we do MRI of the pancreas plus MRCP, and we review the images. If there is any suspicion that this could be a mucinous cyst adenoma, or we're concerned about the possibility that it could be malignant, particularly if the cyst is large, we often ask for endoscopic ultrasound. And the endoscopic ultrasound is basically like a gastroscopy with an ultrasound probe mounted at the end of the endoscope, where the endoscopist will be able to look up the morphology of the cyst, and based on the morphology, it will give us an idea as to how it is compared to the CT scan and the MRI. Added to that, we could take fine needle aspiration, and that fine needle aspiration gets sent for cytology to look for malignant cells or mucus-producing cells. The ultrasound will be able to show us if there are any nodules, mural nodules in the wall of that cyst. Is a very important marker for malignant transformation, particularly if they are enhancing nodules. The cystic fluid will also get aspirated and could be sent for amylase, and it will be extremely high if you have pseudocyst, and also for CEA, the carcinoembryonic antigen, and that is very useful to differentiate between mucinous cyst adenoma and other cysts. Generally, in a mucinous cyst adenoma, the level of CEA in the fluid is more than 200, and that tend to be pathognomonic for mucinous cyst, which means that it will need to be removed surgically. So that's the workup that we do for these cysts. And then we need to know what we are looking for in these cysts, as we mentioned earlier, for the mucinous and the serous cyst adenoma. Usually the endoscopic ultrasound plus the MRI plus the tumor markers will give us the answers, and we can make the diagnosis based on that. But we move on from that into the intraductal papillary mucinous neoplasms. Now, this disease is problematic because of the high risk of malignancy associated with main duct involvement. So there are certain criteria that we have to follow. And these criteria have been studied heavily and revised recently in a paper, and this scheme is called the Fokouka Criteria for IPMN. And what does that do to us is how it helps us. It will help us by dividing the findings that we see on the IPMN, which is usually the main duct IPMN, into whether it has got any worrisome features or not, or whether it has got a high-risk stigmata. Worrisome features are a flag that tell you that you will need to follow the patient really closely every 3 to 6 months, scans and tumor markers. High-risk stigmata mean that you should consider surgery if the patient is suitable for surgery. So what are the worrisome features? These criteria all are built on a few things. One of them is the size of the cyst. The other one is the size of the pancreatic duct. We know normally the pancreatic duct is about 3 millimeters in diameter. If the pancreatic duct is more than 5 millimeters, it's considered as dilated, and then the question of intraductal papillary mucinous neoplasm involving the main duct will arise. So the duct size, the cyst size, and the other thing that we look at mainly is really the presence of nodules, mural nodules. So these are the three main worrisome features that you look at in any intraductal papillary mucinous neoplasm: cyst size, mural nodule, size of the pancreatic. There are other things that could help us, which is if the wall of the cyst is thick and enhancing, that tells you that they are malignant and they might be malignant. You might have a stricture or abrupt cutoff of the pancreatic duct. That's a worrisome feature. And also, if you have been following the patients on serial MRIs and you found that it has grown by more than 5 millimeters over 2 years, given that's the cyst size, talking about the cyst size. So rapid growth of the cyst size is defined as more than 5 millimeters in 2 years on an MRI scan. Now, these patients will get followed up, and a lot of them within the follow-up period we look for these things. And if we have any of the worrisome features that we have found, then we will need to do an endoscopic ultrasound plus sampling of the fluid for cytology and tumor markers. And then we move on to the high-risk stigmata. With the high-risk stigmata, this means that if you have any one of those three features, the risk of having cancer in that lesion is about somewhere between 40 and 60%. And these are enhanced nodule bigger than 5 millimeter. And these nodules will be seen on MRI and endoscopic ultrasound scan usually easily. If you have the main pancreatic duct is dilated to more than 10 millimeters in diameter, this is highly suspicious for malignancy. If you have got a cyst in the head of the pancreas and the patient started to become jaundiced, so obstructive jaundice for a lesion in the head of the pancreas is a high-risk stigmata. Whenever we see any one of those, we will consider surgery. It means that the risk of cancer is quite high. If the patient is suitable for surgery, we need to stage them further and deal with them like we deal with malignant lesions by some form of pancreatectomy. I've chosen some pictures for you to show you how the IPMN appear. So this is an MRI of the pancreatic duct taken from a picture for MRCP. As you see, the pancreatic duct here is quite dilated. It's bigger than 10 centimeters, and there is a cyst associated with it as well. And also you see this appearance of the gray material inside the lumen, which means this is not just watery content of the duct, which normally it is. A clear fluid in the pancreatic duct that we see, but it's here usually mucoepithelial plugs in the duct. This is a high risk feature, which means that a patient like that would be recommended to have a pancreatectomy, probably a total pancreatectomy in this given situation. Now again, side branch IPMN, the best way we see them again on MRCP. So here we go with the pancreatic duct, and here we go with the common bile duct, and this is the duodenum. And we can see there are a few cysts, the white appearing oval and circular lesions in the substance of the pancreas away from the duct itself. So this is a pure side branch IPMN, and pure side branch IPMN has got very low risk of malignancy, and these patients will get followed up by serial MRIs and tumor markers, usually every 12 months MRI and CA19-9 to look for any changes. And if we see rapid changes in the cyst wall or the content of the cyst or appearance of mural nodules on the cyst or the duct start to become dilated, then that would be considered as a high stigmata, and then the patient will be operated on. but the risk of the pure side branch IPMN to proceed to the extent that they need surgery is relatively small. It's about 4% in large series. Oh, this leaves the surgeon with a little bit of a dilemma because of these cysts are a heterogeneous group of neoplasms, and it's hard to tell the diagnosis in a significant percentage of them. We have to balance the benefit of over-treating them, which is exposing the patient to pancreatectomy and all the risks associated with it, or the tragic mistake of keeping a malignant lesion under surveillance, and in a 6 months or a year you find that it has got an advanced stage. So it needs high expertise to be able to make the decision whether to do surveillance or to proceed for surgery. Now, how do we do the surveillance when we think it's either a side branch or a mixed type of IPMN, which is the main group that will go under surveillance? We do annual MRI. If I'm concerned, I would repeat the MRI in 6 months if there is an unusual feature or any of the worrisome features. Then we bring it to 6 months. And tumor markers in the form of CA19-9. And as I said, if one of the criteria for doing the surveillance every 6 months is that if the main duct is dilated, which means there is involvement of the main duct, which is a worry on its own. Otherwise, it would be 12 monthly, and we tend to follow them up as long as they are well and suitable for surgery. Once they become elderly and frail, then we cancel them to say that the risk is small, and even if they develop cancer, they may not be able to go through a big operation, so we don't do anything in that case. And finally, I leave you with this algorithm that is done by the Fokouko Criteria that I mentioned earlier to you, and it basically guides you through the management. It shows you is there any high-risk stigmata, then you proceed for surgery. If there is none, you look for worrisome features. If there is some, you do endoscopic ultrasound until you reach to a final decision for every single patient. I think there have been a lot of work that have been performed on this topic to get the guidelines to appear in this clear and concise way to treat cystic lesions of the pancreas, and in particular is what I'm saying is the intraductal papillary mucinous neoplasm. So this is for IPMN only, not for other cystic lesions. And this has been, initially it was called the Sendai criteria, then it was modified in 2017 and published as the Fukouka criteria for management of intraductal papillary mucinous neoplasms of the pancreas. You could pause the video here and have a look at that. Also, this algorithm is available on the internet. You could download it and use it as a guide for you to manage any given patients. But as I said, the majority will be side branch IPMN, and we will keep them under surveillance, but a significant group of them will be high risk that involve the main duct, which means that we will need to follow them up either very closely or consider surgery in surgically fit patients. Thank you very much for watching the video. I'll be very interested and happy to see your comments and also your suggestions for us for the future. And please subscribe to the channel so we keep going. I'll see you in the next lesson.